Out of curiosity and passion, I actually just took the probe and put it on my own foot and realized that I could see the arteries really well in the foot.
40% of amputations that are happening occur without even having a pre-diagnosis.
The big question here is, if this is so awesome, why isn't everybody doing it?
Jill Somerset had been doing vascular ultrasound since 1999. For years, she watched as diabetic patients with foot wounds made their way through a system where the standard non-invasive tests weren't always reliable enough to show how blood was flowing to the foot. So, one day, out of curiosity, Jill put an ultrasound probe on her own foot and could see the arteries perfectly. That moment launched a new way to measure foot perfusion that now has over 30 peer-reviewed papers behind it. Meanwhile, Abu Khalifa, an ICU doctor, and Adam Gold, a mechanical engineer with decades in medtech, were two friends who had met as fellows in Stanford's biodesign program and were exploring this exact problem. They kept seeing patients showing up too late, losing limbs to disease that could have been caught earlier. And when someone connected them to Jill, the pieces fell into place. She had the clinical breakthrough. They had the lens to scale it. Together, the three of them founded Moonrise Medical to automate what Jill does, so any clinician, anywhere, can measure foot perfusion without years of specialized training. This is the story of their journey and a look into what they believe the future holds. Jill, Abu, Adam, thank you so much for talking to me today. I'm so excited to unpack the story that the three of you have had together on the podcast. There's so many really interesting stories that I think have woven together and are now kind of shared among the three of you. And I'm thinking it could be interesting to start with what each of you were doing before you came together to build Moonrise. And Adam, you had a different background before you came to biodesign. You spent decades building all kinds of technologies and have dozens of patents to your name, and you had a whole life before.
Yeah, I'm on my third life. I think I have 9 lives here. So, I mean, if I go back to the beginning, I have a mechanical engineering background, and I knew that I really wanted to work in design when I was going through my coursework. It's strange to hear this, but as an engineer, I really was not that interested in math and science, although I really liked them. The theory of it it got a little dull for me. What I really enjoyed in school were the projects, and I was hoping that I could use the math and the science as kind of building blocks to build things as a foundation. And so I knew that I wanted to do design. I graduated from undergrad and I realized that I didn't know exactly where I wanted to go. So I did what a lot of people do. I went to grad school. When I graduated from there, I got an internship at a design firm, and I thought, oh, this is going to be this is going to be my dream job. I get to see all these different technologies and I enjoy the creativity of it all. And what I wound up realizing was that 90% of the work was designing computer enclosures, which actually happened to have a lot of engineering that goes into it, but it just didn't excite me. It was tough to get excited about going to work every day. And so I said, I got to do something else. I wound up just getting kind of a referral through a referral, and I got a job at a startup medical device company, and it was actually one that was started by the great Tom Fogarty. And so that was my first exposure to medtech. And I didn't realize that I was really lucky at the time to sort of find my way in there, because it was great to have that whole community as mentorship, just kind of cutting my teeth, if you will. That's what really got me hooked on medtech. And so I actually went through a number of startups. I did a bunch of consulting. I took a detour at one point to start a motorcycle products company, which would probably be a different podcast. But my passion was in medtech, and on a whim, I was looking to get more into the entrepreneurial side. I found the Stanford program. I joked with my wife about how, if I was 10 years younger, this would be a great thing to do. And she said, just apply, see what happens. One thing led to another, and, met Abu at Biodesign, and we started Moonrise a couple of years after.
When you first finished Biodesign together, were you planning on starting a company, or was the future still not that clear?
Actually, I was cheating on Abu. I didn't realize it at the time. I started a company out of biodesign with two other fellows, and we started a nasal drug delivery company out of biodesign. And that took its course to, I don't know how much of this I can say, but it is in licensing phase right now. I think it's just kind of in our blood to just sort of toss around ideas, and there's so many needs out there that when that went to the phase that it's in now, I had some extra time, and we were tossing around these ideas, and we realized that this was a huge need. And so the opportunity was right, and we decided to move forward with it.
So, Abu, you come from a pretty purely clinical world before this, and I'd love if you could share a little bit about your journey and what you're doing in the ICU and what brought you into the world of creating innovation.
I've always, before even getting into medicine or health sciences, I was always interested in entrepreneurship, but I also liked science. I wanted to get into medicine. And I was fairly confused on how to combine both of these together. Most of the mentors around were either clinicians, researchers, or clinician educators. I was the person who was studying for my MCAT and selling fireworks on Victoria Day. My friends grabbed a whole stock of fireworks, and at that time it wasn't easy to get fireworks on stores, inside stores. So we go to find a corner in our town, and we wrote fireworks for sale for the weekend while I was studying in my MCAT in the front seat. So now when I reflect back, I realized I've kind of had it in me for a little while that I wanted to be an entrepreneur. It just took bachelor's, med school, residency, and ICU to actually realize I can actually make it into a career. From there, I went to med school at I got into health sciences at McMaster University, got into medical school there, went into residency and critical care. At that time, I was fairly interested in how do you think about innovation and frugal innovation in a global health setting. So I went to Guyana a few times where I was involved in some global health education work in internal medicine in ICU. And that's where my eyes were opened on how people were using what they had to innovate and really address unmet needs from the local environment, looking at the local needs as well as the local resources that were there. And a lot of times, I thought these innovations we can learn from even in Canada and in the US. So that got me quite interested to explore how do you actually embed innovation with medicine. I didn't know I was going to open a startup. I didn't know how to direct that. And that's what drove me towards Stanford Biodesign. Once I applied to Stanford Biodesign, I took the approach within the program to, yes, learn from the activities, learn from the day-to-day classes and sessions. But I kind of gave myself a little bit of homework and said, I'm going to try to just grab a coffee with one of the mentors from Biodesign and one of the supporters of the Biodesign program at least once a week. And I did that. I met Anurag from Biodesign, and he was like, you should meet Stan Rowe. They're building a medical device incubator out of Irvine. Believe it or not, I'm part of there's a Canadian medicine soccer team that actually competes in World Cups all over. But at that time, I was good enough, so I made it to the team. And we had a tournament in Los Angeles. So I texted Stan, and I was like, Stan, I'm from Biodesign. Anurag gave me your number. And he's like, why don't you just come over and we'll have some milkshake and talk about how we can bring innovation and kind of maybe there's a way to include you in our incubator. So one thing led to another. I finished Biodesign, joined the medical device incubator with Stan Rowe. And then from there, Adam and I kept communicating and talking, and we connected on the unmet need around peripheral arterial disease, foot wounds. And we said, this is really a big unmet need. We need to try to address it. We killed many needs before this one. And this one we could not kill. So we said, might as well incorporate. I connected with one of my good friends. His name is Asim Saleh. He kind of said, with what you're doing, there's Jill Somerset. She kind of discovered something around foot perfusion that is really exciting. You guys should connect. And now we're here.
This seems like a great point in the narrative to hit pause and turn to you, Jill. And I'd love to hear where your story was taking you for the 20 plus years before this part began?
So I've been doing vascular ultrasound, which is imaging all of the arteries and veins in the body except the heart. And I've been doing this since 1999 and really working primarily with vascular surgeons in the outpatient setting, inpatient setting, OR, cath lab. And in 2016, I actually worked with my vascular surgery colleagues, and we formed a multidisciplinary program specifically to try to reduce amputations in our area. And it was really great. It really brought all of the multidisciplinary specialists together to really talk about these complex patients and try to reduce unnecessary amputation. But I have to tell you that during that time, around 2016, 2017, I got very frustrated that our current non-invasive tests, such as ankle brachial index, and that's a indirect pressure measurement where we put blood pressure cuffs around the ankle and the arm, and we do this ratio. And then there's some other tests where we can sample the blood flow in the toe using a little toe pressure and a sensor. These tests have been around for decades, and they were very reliable for patients who were smokers. But now the patients, and I'm sure we can all relate, that we have increased diabetes, increased renal failure, and when you have those comorbidities, your propensity for building up the plaque in the small arteries below the knee and even into the foot, those foot arteries are filled with calcium. Those old ankle brachial index tests and toe pressures really did not provide adequate information.
Jill, I'm wondering if you could explain a little bit more for folks who aren't familiar. So, in a normal vascular scenario, when you're taking that ratio of brachial artery pressure on their cuff and comparing it to the ankle, what do those numbers show you, and what are you learning when you find that those numbers are different in some of these patients? Just to kind of highlight what you were using the information for and how you were learning from it originally.
Yeah. So generally the pressure in the arm, and then we compare that to the pressure in the ankle. The pressure in the ankle, we use a Doppler and we blow up the blood pressure cuff. That blood pressure of the ankle should be equal or higher than the arm pressure. And we do a ratio. And there's well-published literature on the parameters of normal and abnormal. But in patients with diabetes and renal failure, we know that pressure actually is false because that cuff can't compress the arteries in the ankle to get an adequate blood pressure. So it's well known in the vascular community that this ABI or ankle brachial pressure test can be false in diabetic and renal failure patients.
Thanks for walking me through that. And you are so humble, but just to point out to our audience, you had developed so much expertise at this point that your clinic had a specific day where really difficult patients were booked on what they were calling Jill days at that point, just to see you, because your skill as a sonographer was so nuanced and detailed. What were you starting to do to help find more information? Because this seems like it was the beginning of the insight that Abu and Adam were able to work with you to develop some early technology around.
Yeah, well, for the listeners too, I think it's important to know that with vascular ultrasound, we stopped using or imaging the arteries at the level of the ankle. We didn't use ultrasound into the foot. And I think out of curiosity and passion, I actually just took the probe, David, and put it on my own foot and realized that I could see the arteries really well in the foot. And that led to 2 years of rigorous research to look at waveform analysis, ratio, flow volume, acceleration time. We looked at peak systolic velocity, trying to just gather as much information as we could. And through our statistical analysis and data analysis, acceleration time was the most sensitive. And just to break it down for the audience, an arterial waveform on ultrasound looks like a heart rhythm, right? And so acceleration time is a measurement of time from the beginning of the waveform to the peak. So someone with no blockage, they have a very fast peak. Someone with a big blockage, they have a very slow peak. So in 2017, I think it was in August, I was in the cath lab with one of my vascular surgery colleagues, and he was opening up the arteries real time, and I have the probe on the foot, and I could see that change. And it was at that moment that we're like, this is really something. So yeah, I think the discovery hopefully is changing the way we're practicing globally. And I was very fortunate to connect with Abu Bakr and Adam in, 2021, you guys?
Yeah.
2021, yeah.
Jill, I'd love to go a little deeper into that moment because that feels like it must have been an incredible time to live through. What exactly was the realization that came to you when you saw that play out in real time as that vessel was open? Why was that so significant and why was that so meaningful to be able to suddenly see happen?
Well, our goal during any procedure is to improve blood flow. And prior to looking at using ultrasound to look at the blood flow, there was no objective number to really tell us if we've done enough. You know, when we shoot dye in the leg and we do this angiogram, it's very subjective, right? You kind of look at it, you're like, oh, that looks pretty good, not really sure. But this was objective. And what was even better, it was right in front of our eyes. You could literally see the change and say, hey, I think we've improved blood flow right now. And that's really incredible because that's the unmet need. We've never had a way to objectively quantify perfusion to a wound bed in this way.
I've seen Jill in the clinic while they're doing an interventional procedure, and they'll open up an artery and they'll say, hey, Jill, come in here and tell us what the PAT number is. And they will keep opening up arteries until they get the right PAT number. And when Jill, the last time I saw this, when they got the PAT number, right, Jill jumped up so hard she smacked her head on the surgical lamp. But that's the level of excitement and passion that Jill brings to it.
You want that kind of enthusiasm with anyone that you're building with.
But one thing I'll add to that, David, is like, yes, enthusiasm, but like, and again, I'm gonna talk about you, Jill, is her genuine interest to provide and to really be an enabler for better care for patients, right? And you could see that Jill, once she discovered this, you know, the way she's taught it to people, the way she openly speaks about it, the way she tries to teach everyone she meets, to the point that when now I go to a conference, I don't start by saying I'm a co-founder of Moonrise. I start by saying I'm a co-founder with Jill. And like, oh, you work with Jill. Let's go and have a coffee. And I'm like, oh, this is great. Like,
that's really nice.
So this is obviously because of the way that Jill interacts with people, her relationships, her genuine nature with others. So, you know, I'm glad we're in this together. Wanted to make sure I share that.
Thank you.
Yeah. You know, I think the four of us, when we are talking about these patients and these wounds and this difficult anatomy, all have our own sets of images in our mind about what it is like to suffer from this disease. Abu, I'm wondering if you could share what the unmet need looks like clinically, either in the ICU or in these sort of worst case scenario folks who are really suffering from vascular disease.
Just putting my ICU hat on and even my internal medicine hat on, when patients come in with foot wounds, and I see this almost every week, I'm on for an ICU week or covering a shift or something, is patient will come in with extensive wounds. You'll see they had peripheral arterial disease, and you sometimes are the first one to diagnose that there is blockages in above the knee and below the knee. So you're dealing with an infected wound that's progressed, someone's become septic, and now we're trying to control sepsis, we're trying to improve the patient's blood pressure. So we're really at the end stage. And one of the things that comes up is like, I wish we knew, or I wish the patient knew that there is this degree of occluded blood vessels that could have been treated earlier and could have been diagnosed earlier, and then the treatment would have been more optimized, and I would not see you in the intensive care unit, right? So this is a case that unfortunately happens in a lot of our hospitals, and happens all the time, to the degree of making it to ICU, or even to patients who come to emerge all the time, or patients who are back and forth in their podiatry, diabetic foot centers, and their wound centers of wounds that are not healing. So I think the unmet need is very clear, is patients who have foot wounds and aren't diagnosed early enough so that they can be treated, allow the foot wounds to heal faster, prevent an amputation. It's critical, and it's something, when you look at the stats, there's 500 amputations that are happening every day. 40% of amputations that are happening occur without even having a pre-diagnosis. So you're making it to the hospital already too late. So that's a massive number. And when you get an amputation, people, especially below the knee amputation, we're talking in 3 to 5 years, your mortality rate is up to 50%, right? Most patients are actually not going to make it to 3 to 5 years with a below knee amputation. So the stats aren't great. The stats are worse than most cancers when it comes to quality of life and survival. But on a day-to-day basis, when you see a patient coming to hospital quite ill, and then they walk out with an amputation, it's never a great feeling for the healthcare provider or even the patient.
It's such an emotional need to think about. I remember being so bothered by scheduling an amputation. So in my residency, when I was in vascular service, just the concept of it's not trauma, it's not a scenario where there's some massive injury and the limb can't be saved. It's scheduling time on the OR schedule to remove someone's limb, which it just always seemed so wrong that we have to do this. I think that this is starting to feel like the point in your movie for the three of you, where in the audience watching this, I'd feel like, okay, now the movie's starting. Now we've gotten from everyone's backstory and now it's starting to take off. And I'm wondering, Adam, can you share a little bit of that story about what you and Abu were noodling around with this need area and what Jill had developed this deep expertise in and how you came together and what that was like?
As Abu mentioned before, we were tossing around all sorts of different needs, whether it's, pretty much head to toe here, whether it's looking at lung drainage or any other number of needs that we would essentially kill because they all sort of have fatal flaws. And we realized, absent of Jill, we had no idea Jill existed. We just saw this really important need, which is, what we were trained through the biodesign program to identify. And we weren't even looking at solutions yet. We just said, this is something that can be hugely impactful. It's pretty well known within the community. And let's see if we can solve this. We started looking at different potential solutions for it. How can we know if there's enough blood flow to the foot for the wound to heal? And we were looking at all different technologies. And then Abu's friend and colleague said, hey, there's this person, Jill Somerset, that you really should meet, if this is something you're really looking into. And so these sort of two stories were happening in parallel. And I think Jill can explain this better than me, but Jill wakes up early in the morning and 5 a.m. to teach people throughout the world on how to utilize pedal acceleration time. And she does this of her own goodwill. And the big question here is, if this is so awesome, why isn't everybody doing it and everybody using it? And that's the key to all of Moonrise, because it turns out that in order to do this, you pretty much have to be Jill, right? I mean, she's really skilled and she can train people, but there's not enough of them to go around. And so the sonographers, they're not graduating quick enough out of schools. They're underpaid. They're overworked with all the other procedures. And so we just there's this great metric that's out there that Jill discovered, and it works and people love it, but it's just not catching on. Right. And the reason is just lack of skilled people to do this. And so Abu Bakr and I realized that, hey, Jill's got the answer here to this problem, but we need to get it into the hands of everybody. And so that's why we said, okay, let's see if we can start investigating this, but maybe there's a way to automate what Jill is doing so that you don't have to be a sonographer with years of training and experience to do this. I'm going to summarize our story, but we met Jill. It sounds cliche, but we bring really complementary skill sets and I'd say even attitudes toward things. And I think we work really well together. And so we realized, hey, let's form Moonrise and let's see if we can make something to automate this and really make a big change in the world. in 2021, we formed Moonrise, and we are automating the system so that someone who does not have the training that Jill has can take a probe, place it on a foot, and get the PAT reading. And that's what we've been working on.
So I'm so curious as we reach this point in your journey, Jill, how did you get the world to pay attention to this discovery? And also, I'd love if you could kind of highlight what PAT means, because it's a term that we're using and we've sort of alluded to. But maybe we start there. Maybe you can tell us a little bit more about what PAT was and what that discovery was, and then how you got the word out to the world so even Adam and Abu were able to hear about you, because that seems like it's no easy feat in itself.
Yeah, so PAT stands for pedal acceleration time. So pedal meaning the foot. And then that acceleration time is that measurement that I shared earlier, just about the onset of the arterial waveform to the peak. And just to give some more information, in 2019, we published the criteria of PAT in the Annals of Vascular Surgery. And fast forward now to 2026, and there's over 30 peer-reviewed papers. And so we know that PAT correlates to the ankle brachial index test, the toe pressure, to another skin perfusion test, and it's predictive of wound healing. So there's all of this literature that has been building and continues to grow now worldwide. In regards to how, I'm just an ultrasound tech from the Pacific Northwest, but, when we think about the care and the passion that goes into seeing patients heal, I think I definitely got an emotional high over seeing these patients thrive and walk and heal a wound. And that's really powerful, because some of our patients would have otherwise undergone an amputation and would have died an early death. So I think it was 2019, I actually posted it on Twitter, crazy enough. And I just said, I had like one follower, and I said, hey, let's talk about pedal acceleration time. And I just blabbed on and on Twitter. There was one physician named Miguel Montero Baker. He's a vascular surgeon out of Houston. He runs a meeting in Mexico called Hendolat, and he chimed in and said, why don't you come to Mexico and share PAT with us? And so I did. I got on a plane, and there were some big KOLs down there, David Armstrong, Joe Mills, and I got on the podium and talked about pedal acceleration time. And then I just started keeping to post on Twitter. And that's where Abu's friend, Dr. Salah, that's where we met. And that was the connection point. So Twitter really was very helpful in spreading the word quickly through that platform.
I remember I was talking, like, Awesome Saleh went to med school with me, right? So I came back from Stanford, and he's also very innovative and entrepreneur in his own, in his work as well. So when we were talking, he's like, yeah, I mean, he's like, Jill's all over Twitter, right? Like, she's like, everyone's talking about her work, all the big shots, everyone who's doing clinical work is talking about Jill's work. So I'm like, do you mind just like emailing her, connecting? He's like, yeah, you know what? She's going to teach me myself. So I'm going to send her an email. And I still remember, I don't know if I told Jill this, I'd message him every other day. I'm like, hey man, did she respond? Did she get back to you? Because the more I kept reading about the work, the more I recognized that not only she came up with this metric that was getting more and more validated by more and more clinical papers. And that's where it hit us, is that there's a metric, there's clinical validation, there's clinicians that want to use this metric, but there's no technology to allow it to scale in all these settings. And we said, there's something here, right? So I wanted to add that insight as you guys were talking about that particular part of the story.
So the three of you get together, you say, there's something here, let's do this, and you start your company. I would love to understand a little bit better the early ideas for the form factor, and then how that connects to making a difference for patients. You have a way that you'll automate Jill for the masses. How does that trickle down to less patients having an amputation? How does that play out in someone's experience?
Yeah, we started off with a number of different concepts, anywhere from a disposable device to a patch that you can strap on. as is normal course, a lot of them led to dead ends, but you don't know until you go down there. And what we realized is ultimately we needed to make something that was fit within all of the categories of reimbursement, of usability, and usability is really first and foremost, right? And so what we found was that by developing something that had the most power, it was the most sensitive. So just to give an example, we could make a disposable device that had limited number of elements, right? And it would be cheap to make, but it didn't have the power of something that was not disposable and had a lot of elements to it. That trade-off became apparent when we really said, well, what do we need to really make the user experience, the best, right? Because at the end of the day, we have to get the most performance out of this thing. And so we started with the highest performing probe and transducer, and then we started automating from there. And so when you start with the performance, then we were able to say, okay, well, let's craft a business model around this, as opposed to, hey, here's a business model, let's craft a product around that. And so we wound up with a high performance probe and system that was still relatively inexpensive.
And for our audience, when you say probe, you mean something that someone holds in their hand that's connected to an ultrasound machine, and then you touch it to the patient?
That's correct. So
Okay.
an ultrasound machine essentially consists of the probe, which is all the transducers that you hold and put on the foot, and the ultrasound engine, which essentially is the electronics and software to drive the system. And we hook that up to a computer. Really, our secret sauce is in the automation, in taking the information that you would typically see. And when you would see someone like Jill or another sonographer do this, you can watch videos online. And if you've ever had an ultrasound, you'll see they're adjusting all the knobs and the dials and the switches and moving this and that around, right? And that's where all the years of training comes in. What we said is, someone without that training, we need to cut all of that out. So they place the probe and then they get a reading, right? And so all of that automation is really where we've focused on. We started out slowly, just kind of doing proof of concept. And now we've built a team that is mostly headquartered in Canada. And we are pretty far down the road to the commercial system. We're expecting to release it this year.
That's incredible.
David, one thing I'll add to this is kind of like what Adam brought up, reimbursement. A lot of times in early tech development, people think about reimbursement and commercialization as kind of a later stage of development. But as we were in our early concepts and we had, the performance we needed, we actually went and actually delved deeper into what the reimbursement pathway is in this particular area. And I think that probably has served us so well as we started looking into how do we filter, how do we understand, because it gave us an idea on what are important things we got to keep in mind when you consider reimbursement. Who is the user? How do we apply? What is the type of output we should create in the output of a report or output of the scan, so that to make sure that the reimbursement strategy actually fits with what is allowed and accepted. So having that reimbursement strategy early on, now looking back, helped us build a technology that not just worked, but in the future had a business model that would survive the realities of the market. So I think that was, just wanted to add that part because I feel like that was a key part. I remember we spoke to a granting agency about early grants, usually are in prototype R&D development, and we said we want to use it for some reimbursement work. They sent an email and said, wait, are you sure? Like, why would you do that now? Think about that later. Now that I think about it, it was the right decision.
Now, Abu, I'm glad you mentioned that now, because the three of you are so thoughtful, and I can tell how passionate you all are about this unmet need. And when you talk about the strategy for thinking early about reimbursement, it makes me think about what a big problem this is and how many people are unserved that you've been trying to reach. I came across a number that said every 3 or so seconds, someone loses a limb just attributed to diabetic vascular disease. It's difficult to wrap my head around. I'd love to know how the three of you feel about this and how you've shaped your philosophy of the company around bringing care to more people? Because that really sounds from the outside to be core to how all of you are approaching this.
Yeah, I think that there are areas where we can really make an impact. So, whether that be primary care, internal medicine, podiatry, wound care, these are all places that really don't have access to understanding foot perfusion in a quick way. We have vascular laboratories that's a formal ultrasound that sometimes are 6-week wait to get in to see a physician, then to get a referral for an ultrasound. The pathway can be really delayed, and that means delay of care. That means the patient's foot wound is getting worse. And so if we can make an impact at the first touch of the patient, I think that's tremendous.
Yeah. Jill, you have such a fascinating background, and we've touched on a lot of this already. But when I hear what other folks have said about you, your admirers and folks who've worked with you clinically, one of your physician partners said that you are someone for whom monetization and commercialization was sort of the last thing that would come to mind in a good way, like in the beginning when you were thinking about this technology. And as someone that has such a pure approach to what you've been doing clinically, can you share with us how you have threaded the needle from, by necessity, being an evangelist for this particular technology and a company while still maintaining all of that credibility that makes you someone who is just known as Jill in the vascular world, and how you were able to straddle both of those dynamics?
Yeah, thank you for your kind words. I think I try to be very genuine. This comes from a place of really caring for our patients and want to see the best outcomes for our patients. And so I continue to do clinical research. I continue to teach all over the world. But at the same time, there is a need for Moonrise to exist and build this product and to really make an impact that's scalable. And I think that's where I get so passionate, because I want to keep teaching, I want to keep innovating, and therefore the people that actually benefit are our patients. So you're right, I'm not here for the monetization. I have fantastic co-founders. I want to see us have an impact on patient care. But, I also really get a lot of satisfaction teaching people this technique globally. We're making an impact in Venezuela, in India, in El Salvador. Across the globe. These patients are worldwide. And so I think that's what really drives me, is the fact that we can make an impact around the globe by using this technique. And Moonrise is just going to make even that much more of an impact on patients' lives.
It's almost like it's all part of the same passion, whether it falls under your company or the clinical evangelizing that you're doing for this problem.
Yeah, the stars really aligned. There are key time points, the discovery of this technique. Dr. Tesso, a vascular surgeon who actually believed in this technique and locked arm in arm to figure it out, to Dr. Montero Baker saying, hey, come down to Mexico, to Mary Constantino, come in my OBL, let's do this on the table, to meeting Abu and Adam, who are fantastic co-founders with the right moral compass and their drive to do the right thing for the company and for patients. So I feel very lucky, and I feel very blessed that I am on this journey with Adam and Abu as well.
Feeling is mutual. And I got something in my eye. I'm not crying.
Abu, since I asked Jill about kind of straddling these two worlds, you also are straddling two worlds, wearing your hat as an intensivist and also building this company. What is that experience like? Because I know a decent proportion of our audience are people that live 100% in the clinical world and are so curious about what it might be like to step into this blended life.
I'm lucky I went to biodesign at the end of my fellowship, and then I went to biodesign. And at that time, it was early in my career. So I'm just starting a job. So before I went to biodesign, the idea was to go to biodesign, learn some innovation, come back, work in an academic center, and teach what I learned. That's kind of what I thought I was going to do. But then when I went to biodesign, I realized that there are many clinicians who can actually be entrepreneurs. The ratio of clinical work and entrepreneurship work can vary depending on where you are in your career, where you are in building a company. And I recognize at that moment this can be done, right? And that ecosystem, that mentorship that I got there got me to think that, this is doable. So the first thing I did is I told myself, how much entrepreneurship or innovation do I really want to do? Do I want to have a clinical career and do some consulting here and there? That's one way. That's great. That's much needed. Many people do that, which is awesome. Or do I want to really roll up my sleeves and build a company, write IP, build the furniture in the office, and and really start from the ground floor up? Somehow I said, I really want to do that. So I consciously made a decision to work in an excellent community hospital, Joseph Brand Hospital here in Canada. I said, I'm going to work in a community hospital. I'm going to give up my academic position in the academic center because at this point I also work in ICU. So the good thing about ICU, as you know, David, you're on for a week and you have 3 weeks that you can do other work. So I made a conscious decision at that moment that I'm not going to fill up my 3 weeks with clinical activities, whether internal medicine clinics, whether more ICU. I said, I'm going to work for 1 week and the rest of the time during the month, I'm going to work in medtech or some sort of innovation. I didn't know I was going to do Moonrise at that time, but I said, I'll make that call so that when something comes up, I'll be maybe ready. So like you said, it's a tough balance. It's not easy. I was doing ICU last night, and I'm on 1.5 hours of sleep. But that's part of what we do. But I say one thing that's important because when I talk to entrepreneurs, they ask, "Are you an entrepreneur enough?" When I talk to clinicians, they ask, "Are you a clinician?" And I think that's always a challenge. You have this internal identity crisis that you're dealing with. And I say that I may right now, especially as Moonrise has grown, I'm doing some clinical work, but really focusing on full-time plus full-time building the company Adam and Joe.
Hmm. As you three look back on what you've done so far to get to the point where you are now, I'm curious, what's the biggest challenge been to get here?
I think, I pause because I think we don't have enough time, right? But one of the biggest challenges is building a medtech company is tough. And funding wise, it takes a lot of money to get where you have to go. But you have to be very, very cautious with how you spend that money. And there's just a lot of time involved in raising that money as well. And so it's a challenge to make sure that you are feeding the company the fuel it needs to move forward, but at the same time, moving it actually forward. And so there's a stretch on resources, and you never move as fast as you want. But I think as long as you keep moving forward and you get there, then it's all good. It's tough in the moment.
If everything keeps moving forward and you have enough funding to support what you want to do, which so far, knock on wood, seems to be the case, what do the next couple of years look like, Adam, as you grow Moonrise together?
Well, we're definitely coming up on an inflection point in the company. So we've been so focused on the R&D up until now. It sounds like an easy thing. Oh, let's just make it automatic. But actually finding those arteries, identifying them, figuring out what's an artery and what's a vein, doing it within the compute resources that you have, it's a challenge. So our focus has been on the R&D, and now it's more toward developing the commercial product. So putting all the bells and whistles on it and getting it through FDA. But in addition to that, we are sort of rounding the bend here. We're going to apply and hopefully get FDA clearance this year and start going to market. And we are obviously we're going to start small and make sure that everyone who thinks they're going to love it actually loves it. But we're going to start growing that market and hopefully really bringing this to the masses. And then we also have a lot of shiny objects. So not only can this be used on the foot, but what we're doing is we're developing a sensor that automates. We are looking at certain vessels on the foot, but we can look at vessels anywhere on the body, right? And so there's many different applications for this. So we're going to start looking at some of those other applications, and we even have some software that Abu can tell you about more that actually enables the reporting of this. So when you're doing a full on peripheral exam, it takes a lot of time to compile all the information and write the report. So we're developing something that actually automates that process. The idea is still in the same vein of helping the user, which is the vascular surgeon, the interventional radiologist, the tech that's doing the scans, just making it more effective so they can do more and better diagnoses. So the short answer to your question is we're turning toward commercialization, and we're going to start looking at some other applications.
One thing to build on Adam's points is around, the very important, you got to stay focused in a startup, but you also can't stop listening to your customers, right? And can't stop listening to the challenges that they're having, to the opportunities that they're seeing, to some of the solutions that they're working with. It's incredibly important, right? Because some of the solutions that we've built from the primary technology, and Adam talked about some software intelligence solution that we're building for ultrasound labs across. That came from continuously talking to our ultrasonographers, and we're highlighting the problems they're facing, and we talk about our solution, and they keep saying, "Well, you know what? We're still very inefficient in our labs. We're our reporting still takes a long time, and we feel like we can do better. We have so much MSK injury pain because of the amount of scanning you're doing on a day to day basis. So you're listening. You can't just focus on what you want to hear, and
I
that's
just want to highlight this. You're saying that the sonographers are so overworked that they are pulling and straining their own muscles and having injuries just from doing their job. Is that what I'm hearing?
Jill
Yeah.
can build this. Yeah.
Yeah, absolutely. It's
Wow.
a very common injury. You think about scanning in this position, and then they have to sit and type in this position. And they're usually, I mean, we can be ambidextrous, but a lot of people are right-handed, and that is a lot of strain on shoulder and back and neck injury. And so if we could alleviate some of that strain by automating the report, and we can reduce the time burden that it takes to report these complex ultrasound scans, that's incredible. Not to mention the accuracy and the assist, like a co-pilot. I'll let you speak about it, Abu, but there's a tremendous need for evolution of the vascular reporting, not even just vascular, all ultrasound.
Hmm.
Yeah, I think it's a good point. Is the whole concept around optimizing and enhancing the workflow is so important in ultrasound, right? Because when I always say this whenever I talk to investors who don't know the area very well, I say if you ever had an X-ray, you go in, you take a picture, and you walk out, your radiologist is reading the X-ray. Whenever you go get an ultrasound, you're gonna go be in the correct position for the ultrasound. The ultrasonographer is going to come in and scan, and that takes time. Then the ultrasonographer is actually observing and documenting everything he or she saw. And then from there, the radiologist is going to review. So that workflow and that process not only can lead to MSK injury, can lead to inaccuracies, can lead to lack of efficiency. So as we started talking to our customers, and I'm trying to go back to your original question, is as we talk to our customers, we are not really, Moonrise is not just a PAT device. Moonrise is really, we see ourselves as a vascular ultrasound platform that's able to address unmet needs in different areas. We're just starting with PAT because that's where the biggest unmet need is. And now we're moving towards ultrasound intelligence software, reporting software, and building on this portfolio so we can actually empower the vascular ultrasound community.
And all the technology that we've explored on this podcast and that I've explored as you all have doing needs finding, I don't think I've ever come across a market that is truly so strained that the frontline practitioners have injuries from the amount of work they're doing. I mean, that is, it's just incredible to hear that. Jill, I'd love to ask you as someone who was kind of in the trenches, in the weeds, facing this problem for 20 plus years before the three of you began your journey together. As you all move forward and build towards this future with commercialization on the horizon and as Adam and Abu are alluding to, sort of other markets to expand to, other need areas to expand to once you really solve this first beachhead. What is your dream for the future? What's the dream for Moonrise when you think about everything that it could be?
Yeah, there's so much opportunity for improving care. So when I think about using our device outside the foot, a very easy one is patients on dialysis with an arteriovenous fistula, right? It's really important that we understand the flow volume and how well that fistula, that is the patient's lifeline, right? And so we can talk about AV fistula, temporal arteritis, urology with erectile dysfunction. We can look at waveforms in the common femoral vein. There are applications beyond just the foot. And if we can help automate some of those processes and vascular beds, carotid, like it's very superficial, I think that there is a need for our technology.
Like one of the key things or the dream is for our technologies to actually make it to places where there is no access to imaging and care. Right, ultrasound is known as an imaging modality that can actually be in a major hospital or in a village in East Africa. As you know, I come background wise, I come from Eritrea, so East Africa, and I can see the impact that what we can build here can make it to other regions across the world. That's the dream. The dream is to be able to empower providers to provide better patient care, not just in our highest market areas, but to actually put it globally so anyone can benefit from it, and we can actually lead to global impact in patients' lives, especially ones with diabetes, with renal failure. And these numbers are just growing exponentially all over.
Hmm.
Yes, well said.
I think I'd like to close out with a question here for advice for people who are listening to this podcast who maybe are looking to make a career change, maybe are early in their career and hope to one day step into the world of innovation, but don't yet have that unmet need that they know they're going to solve. How would you all give them advice for where to get started and how to step into this?
It's often not the easiest or the most obvious path, right? It sometimes requires taking a detour from what most people do. And so the information isn't always out there on what it looks like, what it could look like. And so as Abu alluded to before, I think the most important thing you can do is reach out to anyone and everyone that may be doing something that looks somewhat similar to something you may think you have an interest in, and just talk to them. Say, what does this look like? How did you get into this? What are your regrets? What would you differently? What's a day in the life like? And the more people you talk to like that, the more you'll really get a feel for, okay, this is a path that I can do, or maybe it's a path I don't want to do. But hopefully, it's something that sparks the vision that I can go down this less traveled path and find my way.
Yeah. I mean, I get a lot of clinicians who come to me and say, I want to be involved in some sort of innovation. And how do I balance that out? I think a big part of it is a sacrifice, right? It is a sacrifice because now you've trained this long in medicine. You expected you're going to be a doctor just full time. And now you're going to adjust your career towards innovation and building something new. I always say, really focus on the unmet need. Clinicians have this, because of the fact that they've trained, they've been involved with so many patients, providers, payers, in various settings. You really have a unique vantage point on unmet needs. So I always give advice to clinicians to say, ignore the shiny objects, ignore all the exciting LinkedIn posts about successful products. Just look at the unmet needs. And sometimes it's this boring unmet need that no one is talking about that needs a change and can actually benefit from innovation. So, my advice is always look for the unmet need, ignore the shiny objects, and then from there, let the process, it's going to take time, and we're going to see where it goes. I mean, we're all still trying to figure it out, so we'll see where it goes.
Well, Jill, Abu, Adam, this has been so incredibly special, and I'm so grateful to all three of you for talking with me today.